Thank you again, and I'm going to speak today about subtrochanteric fractures, and there's an awful lot of ground to cover when we discuss these types of injuries. But there are some things that seem to be recurring themes that I think it would be good to concentrate on them, and in a 10-minute talk, there's no way that I can go through everything possible about subtrochanteric fractures. So I'd like to make some key points through this discussion. One is the importance of fracture reduction. So it's really vitally important to prevent varus alignment when you're treating subtrochanteric fractures. And I think that is one of the most important aspects of the treatment of these types of fractures. Secondly, I'd like to touch on the importance of an indirect reduction, or at least of a biological reduction. Even if you're doing a direct reduction, it can be done in a biologically respectful manner. And this will hopefully help to preserve the vascularity of the fracture fragments and potentially improve healing rates. Ultimately, I'd also like to touch on the two different types of implants that are routinely used to treat subtrochanteric fractures, those being plates or those being nails. What I would hope is that when you're choosing an implant, you're using a rational decision-making process for selecting an implant. And the truth of the matter is that if they're used properly with a good reduction and biologically respectful technique, both types of implants will work well. So why is there a problem with subtrochanteric fractures? So the biggest problem is reduction. As you can see in these radiographs in the upper right-hand corner, it looks pretty okay. Something doesn't exactly look right, but if we only looked at the anteroposterior radiograph, we would say, oh, that doesn't look so bad. But if you look in the lower right-hand corner, you'll see a clear problem with the reduction. So in this case, the anterior apex angulation, the flexion of the proximal fragment, has not been addressed, and the implant has practically missed part of the proximal fragment. And so the alignment of this proximal fragment in subtrochanteric fractures is generally and consistently in varus, flexion, and external rotation, and this is due to the deforming muscle forces that are on it. So we need to do something to improve the reduction from what we see. And there are many techniques that we can use for this, and I've listed a number of aids that we can use to assist us, whether we're doing a direct or even an indirect reduction. And they include joysticks or pointed clamps or ball spike pushers, which some people call picadors, the femoral distractor, or even traction that's applied through use of the fracture table or through skeletal traction on a flat top table. The articulated tensioning device, which we don't see used all that often, but is still certainly a useful instrument. And finally, one thing that's really important to remember is that open reduction can be biologically friendly. So what we do know is the subtrochanteric region is a very high stress area. We do know what the strong deforming forces are. And we know that cephalomedullary implants may certainly have a mechanical advantage, and as was nicely described in the last talk for intertrochanteric fractures, there is a shorter moment arm for medullary implants as compared to extramedullary implants. The nails are load-sharing devices, or so are thought to be. And also, they can substitute somewhat for the medial cortex if it's lacking, and can prevent some degree of collapse into varus, which may not be adequately prevented by a plate. And clinical outcomes have showed that these nails can work quite well. Utilizing long medullary nails for subtrochanteric fractures, about 10 years ago, a series of 52 fractures demonstrated 100% union. And these were done utilizing biologically respectful techniques, joysticks, ball spike pushers, intramedullary manipulators. Well, this is something we don't want to do. The nail is not going to reduce the fracture. So the key is to reduce the fracture, hold the reduction while you place your guide wire, hold your reduction while you ream, hold your reduction while you nail, and hold the reduction while you interlock. And that is the key. If you don't do these, then your technique is likely to fail, and the images on the left do not equal the image on the right. So reduce the fracture prior to nailing. And it's fine to place incisions about the fracture site for this purpose if it's really necessary. So this is an example that I've swiped from Dr. Baumgartner. So this is a patient with a subtrochanteric fracture on the right, has already had a total hip arthroplasty on the left. And this demonstrates a technique intraoperatively of placing a shank screw into the greater trochanter and performing a reduction. A second shank screw has been placed into the acetabulum to help hold this reduction. But if you notice that on the lateral view, which is on the right, there's still some flexion of the proximal segment. So the intraacetabular pin is removed, the ball spike pusher is placed through an anterior incision to help reduce this anterior angulation of the fracture, and then it's once again fixed provisionally with another pin into the acetabulum, and then it's held in that fashion for reaming and placement of the nail. This is an example from my institution, and in this case, this is a patient who was running from the police and was drunk, and he sustained this type of relatively innocuous-looking subtrochanteric fracture. But what you can see is some characteristics that are very concerning, such as the extension into the greater trochanter on the left, and you can see a significant degree of shortening, better appreciated on the lateral view. But with a combination of manipulation, clamps about the greater trochanteric fracture, and skeletal traction, we were able to treat this sufficiently with a medullary device, and he went on to heal, and I'm sure is running away from his other co-inmates in prison. So if we can nail, then why do we plate acute fractures? Well, there are numerous reasons for potentially plating an acute fracture, including a short proximal fragment that we may not be able to get good control of with a nail, involvement of the piriformis fossa, either intertrochanteric or subtrochanteric extensions, greater trochanteric involvement of the fracture, per trochanteric fracture variants, and also reverse obliquity fractures that may extend into the femoral neck. Also, non-unions after nailings or non-unions with deformity may be beneficially treated with plates. So proximal extensions, this is an example of a fracture that extends up into the piriformis fossa, which may preclude placement of a nail, especially a piriformis entry nail. Here's a fracture that extends up into the greater trochanter, which I put a question mark here because you can treat these with nails. You just have to be judicious about how you do it and select the correct implant. And perhaps a trochanteric entry implant in this location might not be a good idea. Intertrochanteric fractures, such as we saw in the most recent talk with subtrochanteric extension. In this case, this is a reverse oblique pattern that may not be well treated with a nail. And finally, extensions up into the femoral neck may also be well treated with plates. Advantages of plate fixation are that we can perhaps get improved control of the proximal segment, and we can get an implant-driven reduction, and especially with some of the newer implants where they're nicely contoured for us to be able to recreate the anatomy. Some disadvantages, however, are that possibly it could be an unforgiving technique. If you place the blade plate somewhat improperly, then you bought where that blade plate is, and you can't change its position short of taking it out and placing it in a different position. Also, the surgical exposure may be a disadvantage, although large exposures can be done in a biologically friendly manner. So the initial objective with treating with any of these implants, but with angled blade plates for sure, what we'd like to do is restore the medial buttress. So somehow we'd like to bring in any of those medial fracture fragments, lateralize them, and bring them back in so that we can create a medial column that can support itself, that is then supported as well by the lateral plate. So we want to get an anatomical reduction, and again, these lateral plates, they're functioning as lateral tension bands, and a tension band will not work if there's medial comminution that has not been reduced. So success rates can vary between 65 and 85% with these, and James Waddell out of Toronto demonstrated that about a 20% failure rate was due to loss of medial cortical support, and then, of course, whether or not the patient was compliant with postoperative weight-bearing restrictions. Well, Brent Ballhoffner and Jeff Mast and colleagues performed a study where they looked back at, they published this way back in '89, so where they did no bone grafting for these fractures. And what they did was they compared a cohort of patients that were treated before 1981 with large amounts of open reduction, and they demonstrated a 16.6% delayed union or non-union rate, whereas indirect reduction techniques that they utilized after 1981 resulted in 100% union rate at normal time intervals. So indirect reduction techniques include use of things like the femoral distractor, seen here on the upper right-hand corner, and the articulated tensioning device seen here in the lower left-hand corner. So in the goal being leaving as much of the fractured area alone with regards to the soft tissues. We have a lot of choices. We can choose to fix these on radiolucent tables. We can choose to do them on fracture tables, and both have advantages and disadvantages. A radiolucent table allows you to be able to manipulate the leg without having it tied up in a fracture table boot, whereas the fracture table, you may be able to generate a little bit more longitudinal traction. The choice of implant certainly we have. So between a DCS, a blade plate, or even the newer proximal femur locking plates. So here's an example of a subtrochanteric fracture with extension up into the trochanteric region. This was treated successfully with an angled blade plate, and notice fairly good apposition in the medial cortex. This blade plate is functioning as a tension band. Newer implants do allow for some smaller incisions, maybe some gentler soft tissue handling, but again, it's really important to avoid stripping. Try to minimize the amount of stripping around the fracture site as best you can. So preserve the blood supply, maintain that periosteum. Whalebone does not heal very well. This is an example of a patient with piriformis extension. So this would preclude perhaps some nailing, also the lesser trochanters involved. Traction views allow us to better assess how well this comes together, and you can see simple traction view does this very nicely. Templated here to place an angled blade plate, and ultimately restoration of the medial buttress, and then the lateral blade plate, tension band device placed, and this went on to reliable healing. So I hope that I've been able to describe to you the importance of three basic things. One is fracture reduction is extremely important. We want to prevent varus. Indirect reduction and biological techniques are very important to preserve the vascularity of the fragments to allow for better healing. And ultimately, there are lots of implants we can use, plates or nails. Either one is fine. Just use some rational decision making when you're choosing the implant, and both will work if they're used properly. Thank you very much.